Welcome everybody to our Hearthside Chat series. My name is Nicole Weinberg. I'm a cardiologist at Pacific Heart Institute in Santa Monica, and we are here to start this series for tonight. So our charity is a women's heart health focused charity. We promote educational symposia during the course of the year, and our big meeting is in February every year. And this past year, we thought we get to these concepts during our meeting, and they're so stimulating, and so many people have questions afterwards. And we thought it'd be really great to have these smaller breakout sessions to be able to tease through some of these details in a more intimate setting, so that people can ask questions and we can talk about these details in a little bit of a more conversational way. So that's how the Hearthside Chats were born. So we have been doing these series and they are very well received. So we're hopeful that this will be great for us all today. One of the things that we talked about at our Women's Heart Symposium this past year was inflammation and heart disease, and understanding how chronic inflammation in the system can lead to cardiovascular problems. So that's going to be what we cover today with our panel of experts and you all asking questions for us. So today we have Dr. Christiane Schaeffler and we have Dr. Amy Kehl, and I'd like them to introduce themselves first and then we'll launch into our discussion.
Great. Hi, thanks for having me. I'm Christiane Schaeffler, cardiologist at Pacific Heart Institute. Really excited to delve into this topic, something that's really become important recently in cardiology. I really was drawn to cardiology because there's so much we can do with prevention, and I think that's really critical for all of us to think about what we can do to lower our risk before things happen, and even after things happen, what we can do to prevent more events from happening. I did my cardiology fellowship at Cornell and an echo fellowship at UCSF, and I'm really dedicated to women's heart health.
I'm Amy Kehl. I'm a rheumatologist. A little bit about myself. I'm a Southern California native. I went to UCLA for undergrad, and I went to UCSF for medical school, and then became interested in rheumatology, did some research in psychoneuroimmunology, stress in the immune system, and found it very fascinating. And everyone that I met that was a rheumatologist loved their job. So I did my residency at UCSD in San Diego, sort of made a tour of California, and started my fellowship at UCSD in rheumatology, and did another year at Cedars-Sinai. And then I started my career actually in academic rheumatology at UCLA, and spent a couple years there as a clinician educator, moved to the Bay Area again, made another tour of California, spent several years in practice in the Bay Area, doing clinical rheumatology, and then we made the decision to come back home, and now I'm with Medical Doctor St. John's, Providence, doing clinical rheumatology. And I think rheumatology is fascinating. I think it's had the most advances out of probably any specialty. I may be biased, but I've always loved how interdisciplinary it is, and how really we can see multi-organ involvement. Certainly we see cardiovascular disease, and there's really overlap with everything. I really do feel like when I see patients, it's true medicine. I'm looking at them holistically, and I love that. So I think this is a great idea, and I'm happy to be here.
We always think of rheumatologists as the puzzle solvers of medicine. So whenever somebody goes through a series of issues and we can't figure out, we say, let's involve the rheumatology crew. And so we're so happy to have you here today. So as it relates to inflammation and our overall body health, why is this important to cardiovascular health? Maybe we should start with Dr. Kehl.
Yeah, sure. I mean, so in rheumatology, just as a little bit of background, we see systemic autoimmune diseases and diseases of systemic inflammation. So that's everything from rheumatoid arthritis, systemic lupus, psoriasis, psoriatic arthritis, vasculitis. These are diseases of inflammation, diseases where the immune system attacks itself. And what we know and what's been well documented is that our patients who have these diseases, rheumatoid arthritis being an example, cardiovascular disease remains a top cause of death and mortality. 30 to 50% of deaths in our RA patients are due to cardiovascular causes. We also see an increased risk of myocardial infarction, 2 to 3 times risk compared to the general population in our RA patients. If you look at lupus, significantly increased risk of cardiovascular disease. We see premature cardiovascular disease. These are diseases that are being diagnosed in one's 20s or 30s. So you think about years of systemic inflammation. So these are patients who may be developing cardiovascular disease maybe a decade earlier than the general population. 2 to 10-fold increased risk of myocardial infarction in our lupus patients. So these are, again, diseases of systemic inflammation. I tell my patients, even though your joints may hurt, your whole body is seeing that inflammation. And that may, and that may be a reason to be proactive about making sure you're optimized from a cardiovascular standpoint. And it's not just RA, it's not just lupus, it's psoriasis, skin psoriasis. So this is, someone may be coming in with rashes, but we know that our psoriasis patients, psoriatic arthritis patients are at increased risk for cardiovascular disease as well. And that's been well documented. And each year that they have psoriasis, that risk goes up. And we have scoring systems. So the more significant the psoriasis, the more the risk. So it's profound. And I think what we're realizing is that the same pathways that are involved with coronary artery disease are involved with inflammation. And I think that's a fascinating thing, is that atherosclerosis is not just a lipid-based disorder. It's truly an inflammatory disorder. And we'll talk a little bit more about that. And I think we have to realize that these diseases are an independent risk factor. So you think of traditional risk factors, which we can talk about, but we really should be thinking about RA, psoriasis, lupus as being an independent risk factor, independent of all these other sort of traditional risk factors, and contribute really to risk just the way that diabetes might.
Yeah, it's interesting. We had a keynote speaker at the Women's Heart Symposium years ago, and he talked about the leading cause of death in patients with Crohn's disease.
Yeah.
He said, what do you think it is? And everybody was suggesting different things related to surgeries and medications and GI insults, and it was heart attacks.
Yeah.
And so it's just something that you don't think about, but when you're dealing with that chronic level of inflammation over the course of decades of your life, these are the things that are really critical. And so I think it's, it becomes really interesting as you think about patients' disease states. And I'm sure you think about that when patients come in and they're worried about that with their cardiovascular health as it relates to their autoimmune diseases.
So we have patients that come in and they just kind of want to get an understanding of their risk. And we have these calculators that we use. One of the common ones that you could even look up online, the ASCVD risk calculator. And that takes into account age, gender, your blood pressure, whether you have diabetes, whether you're on medications for hypertension, whether you're on aspirin. But it really misses some of these other conditions that have been mentioned. And so really it's up to us to actually ask patients about that. Do you have a systemic inflammatory condition? Is it well managed? Do you have a rheumatologist that you're working with? Do you need a referral? Have you had pregnancy conditions that, I recently went to a conference and they asked the crowd of cardiologists, does anyone ask about pregnancy complications? And I think 2 people raised their hand amongst cardiologists, and this is not new information. So I think not only is it on us as practitioners, but I think it's really important also to get the word out that if someone has had an issue in pregnancy or has an inflammatory condition, to really let people know, because you may not have the phenotype or the look of someone we think about with cardiovascular disease. You may be a young woman who otherwise from our other metrics looks quote unquote healthy. Normal blood pressure, normal weight, doesn't have diabetes, but smoldering inflammation that we're not talking about.
And I think it's important as well to realize that a lot of CAD in our RA patients, for instance, is clinically silent. So you may not have symptoms, you know? Another reason maybe to ask about family history as well, really get a sense of what the risk factors are, because, and again, we see a lot of autoimmune diseases in women. There is a predilection with a lot of our diseases for women. So not only is CAD potentially clinically silent, but may also present atypically.
Yeah, and fortunately now we have a lot of imaging modalities that can help us pick these things up early. So one in ultrasound is something called strain, where we can pick up early changes in heart function on just a regular ultrasound. We routinely check it at Pacific Heart, and many other places do too. There's also MRI imaging without radiation, where we can pick up something called microvascular dysfunction, which affects women and men, actually. And there's a whole institute devoted to that at Cedars looking at microvascular dysfunction, and that is very common in patients with inflammatory conditions. So, I mean, knowing about it means that we're thinking about it, means that we can actually look for it, and we can do something about it before maybe the presentation is significant or life-altering.
I do think it's important that you mention the risk calculators, but that it may miss a subset of patients. There was a recent abstract that was presented at one of our conferences about lupus patients who had normal ASCVD risk scores, yet 1 out of 4 had abnormal calcium scores on the coronary artery calcium scan. So we can use these calculators as sort of a guide, but I do think it does miss a subset of patients. Yeah.
And there are patients like we had talked about that come into the hospital and they've had a heart attack and they say, well, you know, I have been going to my doctor and I'm doing my regular physicals and they've checked my cholesterol, they've checked my blood pressure, and they, you know, I'm not diabetic, and they've gone through all the things, and how did I end up having a heart attack? So are there different ways that we look for inflammation now as opposed to, you know, years ago? And are these things that we should be kind of putting into our like regular processing when a patient comes to the office and says, how do I know if I have inflammation and how do I know if it's clinically significant?
I mean, I think from a rheumatology standpoint, usually patients get referred to us because they have symptoms. So whether it be joint pain or rashes, you know, a primary care physician may see that patient in their clinic and say, okay, well, why are you having new onset joint pains? And, you know, you know, maybe they may be more fatigued, but usually there's sort of some symptom that prompts the initial referral. And I will say sometimes markers of inflammation will be checked prior to the referral to me, and that may include an ESR or a CRP, which are considered markers of inflammation in the body. And I think certainly if those are elevated, that may prompt more of an evaluation. And I think it is important to realize that there are different types of CRP measurements. There's a high sensitivity CRP, which we can talk about, which is a little bit more of a cardiac prognosticator. And then there's the inflammatory CRP, which is something that we follow in rheumatology. So when we talk about markers, yes, there are markers of inflammation that, you know, we see, but usually there's a sort of a symptom that prompts the initial referral. And these markers are not necessarily sensitive, the ESR CRP, to any one disease. So they may be high if you had a recent infection or, you know, there was some transient inflammation in your body. But sometimes if there's another symptom that may prompt us to look a little bit deeper, then that's when we start to get involved in, you know, if there's enough of a history and certainly a clinical exam that may suggest that there's some systemic autoimmune process, we may send antibody testing to make sure that someone is not having an autoimmune disease. And if we do diagnose an autoimmune disease, we do follow some markers of both immune activity as well as markers of inflammation, depending on the disease process.
And are there situations where, despite your very best treatments, they're going to remain inflamed for long periods of time, like decades, and then they would be more at risk for cardiovascular disease?
I think that's a good question because we do very much rely on our physical exam when we see our patients in the clinic, and we ask patients how they're feeling. And then these markers of inflammation sort of serve as a guide, but how much of that inflammation is subclinical?
Right.
You know, and I think we do miss some subclinical inflammation, and we know that based on studies that have been done looking at subclinical cardiovascular disease, microvascular dysfunction, which isn't going to be captured with traditional imaging studies. Certainly we miss subclinical inflammation in the joints because I don't have ultrasound vision, although I do use an ultrasound in clinic. But yes, you know, we think of these as chronic diseases, and again, the risk is increased the longer the duration and the more disease activity there is. And we do have disease activity measures that we use for a lot of our disease processes that help us be a little bit more objective in having a sense of how active is the disease, whether it be a skin scoring tool or a joint scoring tool for RA or a lupus scoring tool. We have sort of some tools that we use, but I do think there is a significant degree of subclinical inflammation that we may not be capturing using those tools.
In terms of inflammation in the heart, this just in, can you talk about inflammation in the heart?
Yes. So I routinely check something called high sensitivity CRP in patients when I'm trying to understand if you're at intermediate risk, for example, where it's not clear exactly where you are and I'm trying to determine what would be the next best step. So that high sensitivity CRP can really help me to understand for primary prevention purposes, should I be more aggressive with this patient? Should I get that calcium score that she's talking about to look for calcified plaque, which serves as a burden of disease and might, lower my goals for your LDL and might change the way that I approach a patient. And in patients that have already had an event, a high sensitivity CRP can predict recurrence for future events, so it's really powerful in that way. And then we can look at, why do you have an elevated high sensitivity CRP? Is it just that you've had recurrent infections lately? You had a COVID infection that, I just talked to somebody today and her high sensitivity CRP was 6, and for us around 2 is a threshold of being elevated. And she said, I had COVID when I got that test taken. So you want to check it a few times at least. There aren't accepted standards for gender or weight or age, so I think that's an area for further research. But right now the number is 2, so I really think about what was going on with that patient. And if it's repeatedly elevated and I don't have a clear answer, we think about lifestyle changes actually can make a difference. So moderating alcohol consumption, exercising, things that we think about all the time, and maybe downplay the critical role. Working to improve your, if you're obese, what can you do about that? So there's a lot of things that you can do to kind of lower that inflammation as well, and it can be quantified. So
I think it is important to mention that the ESR in particular is affected by a lot of other variables. So it, even though it'll give you a reference range when you get this test, the upper limit of normal may not be the same depending on your age and your weight. And they don't adjust for that when they give you that measurement. So the ESR naturally goes up with weight and it naturally goes up with age. So if I have someone who's overweight, that may be the explanation, and simply losing weight is a way for that level to come down. But just to understand that some of these measurements are imperfect, and we have to sort of interpret it in the clinical setting.
And I think it's so powerful to have those numbers, because you're actually looking at a number of inflammation. It's like the same as our calcium score. I can actually pull up a CT scan and say, look at the calcified plaque in your arteries. And people's eyes just like, is that really my scan? And there's data that their outcomes improve just seeing that scan and understanding, even if the treatment is the same.
We have a wide range of ages in this room right now, and I'm sure it's reflective of the people watching. At what age should a woman get a baseline on all these tests that you just mentioned?
Yeah, so it's a good question. We're talking about baselines for cardiovascular health in terms of testing. So are there certain times when you start saying to somebody, hey, it's time to start doing certain testing, and if so, about when?
I think part of it depends a little bit on family history. So if you have a really significant family history, I would say somewhere in the 30s maybe, or even by 40, I would say. And if you have maybe average risk, everybody in your family is, or you've had multiple family members with heart disease, but maybe later in life, which for us, early heart disease in a man is less than 55, and for a woman is less than 65, then I would say by 50 would be the absolute kind of latest time to come in. And I have plenty of people that I see, and then they refer their friends or their husbands, so it's not too late. Even if you're past 40 or 50, come in. We're happy to see you and chat.
And I think in rheumatology, part of our guidelines actually is to do some degree of cardiac prognostication, even if a patient is in their 20s or 30s, if they have an autoimmune disease. So if you have a lupus patient, we should be getting a lipid panel every year. We should be watching blood pressure. So these are parameters that aren't necessarily reserved for older patients if you have an inflammatory disease.
I think what's also really interesting in the world of preventative health and preventative cardiology is that, every few years there's more blood tests that come down the pipeline as interesting things to kind of scratch the surface and see, okay, well, this person has all these normal variables, but their, apolipoprotein B is now elevated, or their lipoprotein a is elevated. And so it kind of prompts a little bit of a different workup in terms of where their risks lie and how you would be evaluating them, because perhaps you wouldn't do a coronary calcium score on somebody until they're after age 40, which is where most of the data starts. But if their lipoprotein is extremely high, showing that they have a genetic risk of this inflammatory condition, then you may want to, talk to them about, doing some other testing sooner than that. So I think it is really interesting, and every year there seems to be more pieces of this puzzle that get allowed by insurance companies to be drawn in terms of just basic blood work for testing. So it doesn't mean that if you come to a cardiologist, you need to have an angioplasty right away. It means that maybe you're just going to get a blood assessment and a little bit more of a look in terms of where your risks lie. And so what I think is really important, and this leads us to one of the questions in here, is let's say you are told that you have some increased inflammation, but perhaps are not necessarily tied to a disease process where you're being monitored and getting infusion therapies or whatnot. How do you modify your lifestyle or your foods or exercise so that you can try to lessen that inflammation so that that's not going to become a significant risk for your cardiovascular health?
I mean, we can sort of extrapolate from our inflammatory conditions about lifestyle interventions that have been studied. So when we talk about good studies, we're talking randomized control studies, and there's now 2 very good randomized control studies looking at the Mediterranean diet in patients with inflammatory diseases, RA and lupus, but I think we can extrapolate to a general population who has, some degree of risk, and even without risk, is just shown that those patients just do better, both from a cardiovascular standpoint, but even from an autoimmune standpoint, their joint pain gets better, their joint swelling gets better. I mean, it's certainly, we use it as an adjunct with all our other treatments, but you think about a Mediterranean diet, it's not that restrictive. You don't need to be cutting everything out. It's a colorful diet. You think of your plate mostly vegetables, and if there's a protein, something high in omega-3s, fish, extra virgin olive oil, healthy fats, avocado, less processed foods, less saturated fats. The same interventions that are used in cardiology as far as lifestyle changes apply in rheumatology as well. And it's not surprising because, again, those same inflammatory pathways are the driver for both atherosclerosis, same inflammatory mediators as in rheumatic diseases. Certainly weight loss, if someone is obese, is one way to modify risk. So, we can steer the course of the ship, I like to say, even if you have some genetic predisposition. And it's interesting in our world, we talk about obesity a lot because we deal with arthritis, osteoarthritis, weight-bearing joints. It makes sense that if you're carrying more weight, that we might see earlier osteoarthritis in the weight-bearing joints, but we see premature osteoarthritis in the hands in obese patients. Why would that be? It's not a weight-bearing joint. There is something about those adipokines, those fat cells that mediate early arthritis, earlier inflammation, outside of the fact of, just gravity and weight-bearing joints. So weight loss and dietary changes.
And also, just to, in terms of the prevention piece of the puzzle, there are medications that people would take over the counter, say they're having lots of pain, joint pain, and they're on NSAIDs, high doses of it, that can be very dangerous to cardiovascular health. So that might be something that you would want to dial into sooner than later, because you don't want to be taking these high doses of your NSAIDs to deal with your joint issues, because that can affect your cardiovascular health later on. So it's important to fold it all together. I don't know if you wanted to wax poetic about some of the prevention piece of the puzzle.
Yeah, I think another thing that I ask everyone about is what your sleep is like. And I think unless you ask, people don't say anything. And a lot of times people say, oh, my friend actually has problems with sleep, or my partner snores all the time. It's so irritating. But beyond just being irritating and you have to wear earplugs, they're actually not getting enough oxygen at night potentially. So that is a very important cause of smoldering inflammation that I'm really passionate about screening everyone for that. It increases your risk for cardiovascular disease, stroke, arrhythmias, can affect your memory, your mood, can make it harder to lose weight, it increases your blood pressure. And there's definitely increases in cortisol that have been measured. So I think it's something really important to get out there and spread the word about that. There is something called a stop bang score that you can look up online and see what your risk is. And just being over 50, having high blood pressure, even being on one medication for blood pressure, you already have a couple points there. So you would be surprised how many people are at high risk for this.
Yeah, and I think tobacco cessation, if someone smokes, I feel strongly about encouraging by any method possible tobacco cessation, and that's of course, a risk factor for cardiovascular disease, but it is a risk factor for autoimmune diseases as well. You know, we think about our diseases as being this combination between genetics and environmental triggers, and we haven't identified all the environmental triggers to create sort of this perfect storm in autoimmunity, but the one trigger that we definitely know exists is tobacco. And there's some theories that some inflammation really starts in the lungs before it goes to the joints, and you know, it's not just a risk associated with lungs, it really is very well shown to be a risk factor for autoimmune diseases, rheumatic diseases, and progression of those diseases. Those patients are more likely to progress if they smoke. So I think, you know, that is an important lifestyle piece.
Now, you had mentioned pregnancy and cardiovascular disease, and could you kind of talk about some of the different pregnancy conditions that create inflammation within the system that put you at risk for cardiovascular problems?
Yeah, so every time I see a woman in clinic, I ask them, what were your pregnancies like? Did you have preterm labor, like around 6 months? Did you have something called preeclampsia, where you had elevated blood pressures, or gestational diabetes, gestational hypertension? That does increase your risk for incident cardiovascular disease, and that means that we should be screening you sooner. And it can be really telling in terms of earlier heart disease coming up that you may not have thought about talking to anyone about because you're not following with your OB anymore and nobody ever asked you. Something to think about.
We always talk about in rheumatology optimizing patients before pregnancy, because we know, again, we talk about disease activity, that if the disease is active, meaning they are having active symptoms or there's active inflammation, that is much more likely to predict poor pregnancy outcomes for mother and baby. So, you know, increased risk of preeclampsia, preterm deliveries, you know, and certainly with some of our disease processes, there are unique risks that exist for pulmonary hypertension, then postpartum as well. So it is a risky time, and we see it. There was just a study again that was published for patients with vasculitis, and those patients had significantly increased risks in the postpartum setting, specifically 20 to 30% risk there. So that risk is very real in our patient population, and our goal is always to make the disease as quiet as possible, minimal inflammation, really at the time of conception, to predict good pregnancy outcomes, both for mom and baby.
And also, I bet there are issues even getting pregnant if you're very inflamed. There's a lot of interesting data coming down the pipeline about inflammation, large inflammation such as, you know, being in a lupus flare, but also smaller inflammation relative to microbiome health and things like that as it relates to fertility issues and getting pregnant. And that's like kind of almost like a smoldering level of inflammation that you have in your system instead of this really loud, big diseases. It's almost like you could miss it if you weren't really looking for it.
Actually, one of the more common referrals to our clinic is infertility. That's unexplained because there are some antibodies that we screen for that are associated with recurrent miscarriages and infertility. And you think of antiphospholipid antibodies being a risk factor for clotting. And sometimes that clotting can happen on a micro level that can cause early miscarriages, recurrent miscarriages, and clotting events, you know, without having an overt clot necessarily. So that would be a reason that a referral might come to us from, say, an OB, and that does come up.
Yeah. And it's also interesting thinking about some infectious issues like COVID and things like that as it relates to cardiovascular health with some of the direct inflammation of cardiovascular disease. I don't know if you want to talk about some of that stuff that we've seen in higher numbers recently.
I think we've seen so many different things from COVID, anything from rhythm disorders, from the smoldering kind of inflammation of the heart muscle that people experience, sometimes changes in the way that their heart rate kind of is regulated. And some of that we see kind of as improving over time. We don't really have a lot of data behind kind of how to treat those, but a lot of it is symptom driven. So I've used imaging, sort of like MRI studies, to look at the myocardium directly. And that's helped me create a treatment plan for patients. Sometimes inflammatory mediators could help with that. I've also made referrals to electrophysiologists at times when I've seen rhythm issues, and we were able to look at that with a monitor. I think in our last session of the series, we talked a lot about Apple Watches and monitors, and sometimes we can pick things up that way, that there might be some dysregulation in the autonomic nervous system.
in terms of therapies for patients that have like a chronic level of inflammation or some sort of autoimmune condition, can we maybe talk about the options for treatment? What is out there? It used to just be steroid, which has its pros and cons.
Double-edged sword.
Yes.
As I said, rheumatology has advanced so much that, what we used to use as the cornerstone of treatment really is now considered just a bridge. Prednisone is a bridge. And now we have so many what we call steroid-sparing agents that we try to use in targeted ways, depending on the disease process that we're treating. So again, we see, different cytokine profiles depending on the disease, and now we can target those specific cytokines that are mediating the inflammation depending on the disease process. So, TNF alpha, you think of treatments that block that in rheumatoid arthritis. That was a game changer. But now even more specific, interleukin-6 in rheumatoid arthritis and vasculitis. We block the specific cytokine that's causing that inflammatory cascade. And it's been a complete game changer to have these new treatments that, every year there's something that comes out. Psoriasis, interleukin-17. So very specific targeted treatments, and our goal is now to put the disease into remission and really use less of the steroids that used to be such a cornerstone. And sometimes it's necessary to really get the disease quiet to use steroids at the beginning, but now we really make an effort to use these steroid-sparing therapies. And what's so interesting are that these mediators, TNF alpha, interleukin-1, interleukin-6, are now targets for cardiovascular disease. So, and it just in the last year, this is being looked at. And I think that is something that's very exciting because maybe we can be augmenting cardiovascular risk using the same sort of methodology we've been using in rheumatology over the last decades. Yeah.
Do you want to talk about colchicine a little bit?
So there have been a lot of different sort of studies. This year is the first approved indication for an inflammatory medication for cardiovascular disease using colchicine. So there was a trial called the LODOCO trial looking at low-dose colchicine in patients that have had cardiac events in the past, and they actually were able to reduce recurrent events by up to 30% in some individuals with low-dose colchicine, which is something that is relatively inexpensive compared to some other medications, is relatively well tolerated. About 10% would discontinue it due to GI side effects, but it had a really powerful improvement in outcomes. And it is really telling us that beyond general therapy, such as lipid lowering with statins that we usually think about, there is this other piece of the puzzle with inflammation that we have not been addressing because there haven't been those really great studies that we're talking about, the randomized, double-blind, placebo-controlled trials. And now we have powerful medications to address that. And prior to the LODOCO trial, which was just a few years ago, that was 5,000 patients, there was a study in 2017, which is a proof of concept study in a biologic for cardiovascular disease. And that trial looked at a blocker for IL-1 beta, which she was just talking about, in patients with a high sensitivity CRP, which was elevated. And it showed a decrease in events. So by at least 15%, and patients had no change in their cholesterol panel, which is really powerful for us, that people with known cardiovascular disease with really well-controlled cholesterol panels could have further reduction in their risk by just targeting inflammation. And that was the first kind of study of its kind that really is putting these medications that she's talking about on the scene for us as cardiologists.
And if colchicine sounds familiar, it's because we use it for gout. So it's a tried and true treatment for gout, pseudo-gout. We have a lot of experience using it in rheumatology for gout. So isn't that interesting? I think it's such a unique drug that it would work for cardiovascular prevention, but it makes sense because, again, we know our gout patients are at risk for cardiovascular disease. And that, again, another big study this year that showed independent of urate levels, controlling for the typical cardiovascular risk factors, there is an independent risk with gout and cardiovascular disease. So again, why would that be? One of the cornerstone, causes of gout flares is this neutrophil inflammation, this high neutrophil to lymphocyte ratio. And now, it makes sense that something like colchicine would mitigate those flares by targeting pathway. So, I always try to think of what's the mechanism, why would it work? And it makes sense. And even, blocking interleukin-1 is a way to lower that ratio, that neutrophil to lymphocyte ratio. So the same mechanisms that we use to treat some of our inflammatory diseases are working for overall inflammation. Again, underscoring that atherosclerosis is not just a lipid-based disorder. It truly is an inflammatory disorder that really involves all components of the immune system.
And I think because using anti-inflammatories can reduce your blood cell counts, it's really important for us to work alongside rheumatologists. And now there's this emerging cardio-rheumatology field, because in that one study that I mentioned, one issue was there were a lot of infections, and some of them were fatal in the IL-1 beta inhibitor trial. And so I think we need to work together to be screening patients. Are their blood counts staying normal? Do they have underlying conditions like TB that we need to be looking for before we start those medications? And so for us, it's newer. And so I think working alongside other fields is really powerful.
Yeah, it's an evolving field of cardio-rheumatology, but how great that we have this interdisciplinary, discussion, and, that you're right down the hall, basically. Yeah. I now am much more inclined to prognosticate patients, knowing all the data we have. And it is part of our job to say, okay, is this patient high risk? And refer to cardiology to say, what's the right imaging study to order? Because our diseases, it may not be coronary artery disease alone. It could be microvascular dysfunction. It could be myocardial disease. It could be pericardial disease. So who should get the calcium score? Who should get a TTE? Who should be getting an MRI? And that's why we work together, because we really want to make sure we're thinking deeply about these patients, really targeting the underlying mechanism and then optimizing them, because, again, we want to catch these early before events happen.
So we could keep chatting, and I have a lot of questions, but if there's anything that comes up in the audience, feel free to just raise your hand or interrupt. Yes.
So were some of those therapies that you both discussed biologics? Is that the category that they're in?
It's a good question. So colchicine is not considered a biologic. So in our world, we talk about disease-modifying drugs, oral DMARDs, and then biologic drugs. So oral DMARDs may be things like methotrexate, which is used for rheumatoid arthritis, which, again, reduces cardiovascular risk if we're treating the underlying disease. Hydroxychloroquine, Plaquenil, which got a lot of press during COVID times, which we use all the time, not just for lupus, but inflammatory arthritis. It's used for cutaneous diseases, sweets. That's considered an oral DMARD. Again, we see less diabetes, less cardiovascular risk, disease. We see a clot protection with Plaquenil. So these are oral DMARDs. The biologic drugs is a different category together, and they're engineered from living cells, and they're targeting specific cytokines. So that's a lot of the TNF blockers, the interleukin blockers, interleukin-6. A lot of them happen to be injectable drugs, sometimes infusions. We do have an oral biologic, which is a JAK inhibitor. So there's a whole class of biologics, and then there's the whole class of oral disease-modifying drugs. But yeah.
Can you explain, for those of us who aren't in the medical profession, what's the biologic versus the other? What do each of those mean?
Yeah, so biologic means it's engineered from a living cell, and it's targeting specific antigens or specific cytokines, whereas oral DMARDs may be chemically made in a lab. So it's the way they're engineered is different. Yeah.
And in the world of medicine, I would say, rheumatology kind of started with all the cool drugs. They had all the really fancy stuff, and we're all very jealous of all the fabulous drugs that you had. And interestingly, over time, a lot of that same technology is being used in the world of cardiology. So we have a bunch of different medications that we now use for cholesterol lowering therapies that kind of fall into these different categories as well. So a lot of them are very desirable drugs to be on, because if you think about statins, which is one of our cholesterol lowering mainstay therapies, some of the side effects associated with them are joint aches and muscle aches and things like that. And so now we have some injectable biologic therapies that we use for patients that are not processed the same way. So they have a completely different and much lower side effect profile associated with them. And also they seem to last in the system longer, so you don't have to take a pill every single day. So we kind of are, there's a little bit of a joke in medicine that like patients will ultimately just be coming in like the Jetsons. You know, they'll come in for their, you know, their Prolia shot, their Humira, they'll come in for, you know, their other, their
And I would say the
agents.
biologic drugs tend to be more immunosuppressive versus, say, immunomodulatory. Say, like the Plaquenil, the methotrexate, I think of those as more immunomodulatory, sort of modulating the immune system on a low level. Colchicine, I think of it as a very unique drug in the way it acts, but not immunosuppressive in the way that the biologics are. So when you hear about risks of infection, it's usually referring to the risks associated with biologic drugs. And it makes sense because we're telling the immune system to calm down. So, our normal immune system should be fighting bacteria and viruses, not our own bodies. So, when you tell the immune system to calm down, the ability to fight infections goes down as well. So for us, it becomes important to choose the right candidate. We have to be smart about who we're choosing when we're choosing these drugs. If we have someone who's in and out of the hospital, say with infections, they're not going to be a good candidate. Who has a history of latent TB, or chronic hepatitis, those aren't good candidates for some of these biologic drugs. So, but we screen, we choose carefully, but the patients who are otherwise healthy, they do very well.
And in some sub-study of that initial trial, I was saying they actually saw a decrease in lung cancer incidence that was fairly significant. And that was an interesting finding. And we think probably it's because there were a lot of smokers in that trial that also had developed coronary disease. So there's a lot of intersection. Maybe that's another topic. We'll do a hematology oncology day. But
I do think we borrow a lot from other fields. We all learn from each other, right? Hydroxychloroquine was an old anti-malarial drug. It was a drug used to treat malaria. And then it worked for autoimmunity, and methotrexate was a chemo in high doses. So we borrow from oncology, we borrow from other specialties. We all kind of start to realize, and sometimes these things are found accidentally. They realize, oh wait, there's some signal here that this might work for another disease process, and that's the nature of research sometimes.
And how about boosting your immune system? Are there certain things that people can or should be doing to boost their immune system and to fight inflammation in other ways?
I mean, we of course advocate for vaccines. So especially with the drugs that we use, we want to make sure everyone is getting age-appropriate vaccines. I think, there are some patients who truly have true immunodeficiencies, and that's a unique entity. But, again, it's the things that are in your control, right? Avoiding bad habits, avoiding tobacco, eating well, Mediterranean diet, keeping the weight in a healthy range, exercising. Those are the things that are in our control. And then there are things we can do to, prevent increased risk. And, sometimes if we have a patient who has recurrent infections for whatever reason, we're screening a little bit more for immunodeficiencies. But, I think it really comes back to those lifestyle factors. And I don't think that everyone needs to be taking excessive amounts of supplements, although there is some research that, omega-3s, fish oil, may be beneficial for our inflammatory diseases, less joint pain, less joint swelling in our patients with lupus RA. Certainly there's a role in cardiovascular disease. There's some softer data for curcumin, and ginger seems to have some effect on neutrophils, interestingly. So, these are things that aren't going to hurt you that may help you. So I think we're learning more about that.
And I'm hoping to get more trials to come out so I can kind of help me to understand who would really benefit from some of these. So the biggest trial that we have for a supplement, quote unquote, is for fish oil, is the concentrated EPA in patients with elevated triglycerides, even above 135, which is generally not considered that high. Usually it's 500, which is our high threshold. Did seem to benefit when they had a history of heart attack with a trial that was randomized, double-blind, placebo-controlled. So looking for more of those trials in the supplement world.
We have few RCTs, randomized control studies, and the ones that have been done have been with omega-3s, fish oil for RA and lupus. So we need more of those for other supplements.
So everybody should have fish for dinner.
Yeah, I think, but I think you may not be getting enough omega-3s with just fish. So, there may be a role in a select population to take an additional supplement, in the right formulation.
How about exercise? We're talking about, reducing inflammation. There's a lot of good data that supports exercising, but in patients that have certain autoimmune conditions, they may find that exercise is really painful and they can't do that. Are there certain
It's true.
tricks?
I mean, we deal with hip and knee osteoarthritis that can be truly debilitating. I mean, patients can have a hard time walking and participating in exercise, and that leads to obesity, which then leads to cardiovascular disease. So I think it's important to come up with strategies to get patients physically active, and that may be aquatics, getting in a pool. It's a non-weight bearing form of exercise. So I often refer to aquatics therapy in my patients who have osteoarthritis because it is a way to get aerobic exercise. There are some patients who do better with an elliptical than with weight-bearing land-based therapies. So we try to come up with strategies so that we can sort of break that cycle. And I think certainly pain management sometimes becomes important when we're dealing with osteoarthritis, which is a different condition than, say, rheumatoid arthritis. And we find, there are some patients who, need targeted treatments so that they can be functional and mobile again. But it's an individualized decision.
And I think exercise also, we always talk about it with the role for exercise with improving mood and depression, just kind of underlying mood disorders can really contribute to this low-lying smoldering inflammation. And then something else that I think we don't talk about enough is like oral kind of periodontal health. There's a lot of association with, just not keeping up very good oral hygiene and cardiovascular disease. And that's something that's, relatively simple, just a few minutes a day and a few visits, I guess, to your dentist every year, but really important.
Getting back to those environmental risk factors, those triggers for autoimmunity, for rheumatoid arthritis, we talked about tobacco, but periodontal infections is well-documented risk factor for RA development. P. gingivalis, the organism that's involved with periodontal infections, is a trigger for the immune system. So, importance of really, optimizing health in other parts of our body, including our oral health as well, becomes important.
So in terms of inflammation and age, are there certain disease processes that appear later in life? Are there certain things that, like, as we age, inflammation worsens or improves? Are there certain things that we should be paying attention to?
Yeah, I think a lot of our diseases are diseases of young women that present in younger ages, but we do see late onset diseases, late onset inflammatory arthritis. And again, we're still trying to figure out why. Why do some patients develop later in life, new onset RA? I mean, a classic example of an inflammatory condition that may develop later in life is polymyalgia rheumatica. Certain types of vasculitis that are associated with polymyalgia rheumatica. It's an inflammatory condition, typically patients over the age of 60. That can present with sudden onset of shoulder, hip girdle stiffness. Patients suddenly have a hard time getting out of a chair, lifting their arms up over their head. They have significantly elevated markers of inflammation. ESR, CRP are usually through the roof, and very responsive to steroids. But yeah, we do see late onset disease, things like vasculitis, polymyalgia rheumatica, but also late onset RA as well. And then, I do think that there are conditions that can come and go, wax and wane, and I think there's various reasons why we may see that, and I think hormonal changes are a big one, and I think we can't underemphasize that, that some diseases become quiescent, say during pregnancy, yet flare postpartum, and then there are some conditions that kind of quiet down as estrogen goes down, and other conditions that do the opposite. So I think that the hormonal triggers are a big one.
So it does seem like taking anti-inflammatory medications seems like a great idea, but is there a risk of taking too many anti-inflammatory drugs? Like, if everybody just says, well, I don't want any of these things that you're talking about, give me all of these drugs, are there risks of having too many anti-inflammatory drugs in your system?
I think it really depends on the disease process and the drugs that we're talking about. And, I think everything in medicine is risks and benefits, and we try our best to make sure that the benefits are outweighing the risks. But, I think when you think of what's over the counter, ibuprofen, Motrin, Aleve, naproxen, those are not without risks. And I think they're very effective in treating arthritic pains. But I think, I always tell my patients, we want to really use as little as your body needs to keep you comfortable without taking an excessive amount. And there are some patients who need some degree of an anti-inflammatory, but we watch those patients. I involve my cardiology colleagues. Are they optimized? Do we need to be avoiding these completely? we should be monitoring kidney function every 3-4 months. I'm pretty strict about that if I have someone who's on an anti-inflammatory chronically, meaning over 3 months, gut protection, proton pump inhibitor. So, I think sometimes it's necessary to have a functional quality of life to be on some sort of pain reliever, but at the same time, we want to make sure, at the very least, we're monitoring for risks.
And also reporting what you're taking, because they're over the counter, so a lot of people don't talk about it and don't tell their physician they're taking several Advil a day or several Tylenol a day, and they're not without side effects. Some people say that if some of those medications were tried today, they wouldn't get FDA approval. So
it's always interesting to me that ibuprofen, Motrin, Aleve are over the counter, but statins are not.
Right.
Yeah. I mean, they should be, right? I've always thought that. But we can get very risky drugs over the counter that also require monitoring. So, I think anything that you take, I think just report it to your doctor. And, we try our best to make a good risk-benefit sort of assessment. But it really is this balance. And some patients, we want to make sure everyone has a functional, long life where they're not just, having, a long life, but also a life without pain and, a functional life where they can be active and do the things that are important to them. So prioritizing what's important to the patient, also individualizing the treatment for the patient.
Yeah. We have a question over here.
Yes, you mentioned several situations, and I don't know the definition of them. Vasculitis, you mentioned several times. What does that mean, and what do some of the other things that you mentioned mean in lay terms?
Yeah, vasculitis is an autoimmune condition. It's rare. That's associated with inflammation of the vessels. And that may be the small vessels, and that can manifest as, say, a rash. It may manifest as kidney injury or pulmonary disease. There are medium-sized vasculitides, and there's large vessel vasculitides. The large vessel vasculitides, of course, are serious. They can affect major organs. They can affect the arteries of the heart. They can affect vision. And so when I'm talking about vasculitis, it's referring to this family of inflammatory diseases that are really autoimmune in nature, although there's various types. So that's different than, say, vascular disease, and I think those two can sometimes be confused, but vasculitis is very much an autoimmune entity.
For us, vascular disease could be carotid disease, carotid artery disease, could be coronary disease. We talked about the microvascular, the small blood vessels that perfuse the muscle of the heart. Could be peripheral arterial disease. So for us, screening for a lot of that is also really important. Feeling your pulses. And sometimes there can be sort of great mimickers. So sometimes patients say, oh, when I'm cold, I notice that my fingers turn white. That's actually something you could think, is it an arterial issue? Or is it actually related to an autoimmune phenomenon known as Raynaud's? So we use some of the same medications for both of those, but there is overlap again in something like that.
And that same pathophysiology that causes Raynaud's may also cause vasospasm in the heart. So I think when we think about the heart, we think about the coronary arteries, right? We think about the pericardium, we think about the myocardium, we think about the microvessels, and then we think, and I think it's helpful to think in those types of categories, especially dealing with autoimmune diseases, where really any part of the cardiovascular system can be involved in different ways. Yeah.
We have about 5 minutes left, so I thought I would maybe ask each of you to kind of give us a few bullet point take-home messages for our audience of what are some things that we should just remember in terms of reducing our inflammation and being healthy for long periods of time.
Yeah, I think be proactive with your health. I think, don't dismiss your symptoms. I think as women, you may not present typically, with the classic chest pain, for instance. And, certainly if you have a family history, to mention that to your doctor, because maybe you do warrant screening. And, from an inflammatory standpoint, think about the things that are in your control that may, again, steer the course of the ship. So, keeping your weight in a healthy range, Mediterranean diet, avoidance of tobacco, getting good deep REM sleep. The things that, that are somewhat in your control, I think, are the things that we can modify. And of course, we try our best to really get a sense of what your risk is. And that's, that can be a multidisciplinary conversation. So.
And I think, I would echo all of those things to really help us with cardiovascular risk prevention. And I think ask a lot of questions when you go and see your physician, and be sure that somebody that's talking with you is also listening to what you have to say, and asking really provocative questions about your conditions, about your symptoms, about, did you understand what we talked about? And you're asking, do I need more of an evaluation? Should I look into this symptom that was a little bit strange? Or, I'm going to actually spend time thinking about myself and what's going on with me, and not taking care of everyone around me all the time.
Which we are always at risk for. But I think those points are really critical as it relates to one of the reasons why we really wanted to do the Hearthside Chats, because really we go to meetings and we talk the talk, and we know what's, maybe current in the world of medicine. American Heart Association is going on right now. There's some big rheumatology conferences that are going on. But to empower the patient who is maybe not completely dialed into all the latest and greatest, to say, what else should I be getting? Should you be checking some other advanced lipid markers? Should you be checking my inflammatory properties? I had a family member that had this very unusual condition. How do I know that I'm not at risk for these things? Oftentimes there is more of an itch that can be scratched with your practitioners. And I think just, really feeling like you're in charge of your medical journey is very, very important. And so we hope that this, in some capacity, empowers the group. If there are no other questions, I want to thank you all for spending the night with us. We've had such a good time, and we feel this has just been a wonderful journey, and we look forward to many, many more Hearthside Chats. So from all of us at Have a Heart, Save a Heart charity, thank you so much for being a part of this tonight. Thank you.
Thank you.